Kia ora koutou, no mai haere mai to tonight's Te Whatu Ora and Goodfellow Unit Interactive Webinar. My name is Katie McCulloch. I'm a nurse practitioner working in primary care and for the Goodfellow Unit. This is a collaborative webinar series that will be running monthly to support primary care, and each webinar will focus on clinical topics and clinical updates. These webinars are run slightly differently to our normal setup. Each topic will have 10 minutes of presentation, and there will be an opportunity at the end of each section for a 5-minute Q&A pertaining to that topic. Tonight, we're going to be looking at measles, what the outbreak response team wants you to know, jaundice in infants, and abnormal uterine bleeding updates and audit learnings. And we'll finish off with a few clinical updates. We're joined tonight by a great panel of experts and colleagues to discuss tonight's presentations. Our speakers include Dr. Rebekah Doran, Clinical Advisor, Care in the Community, National Public Health Service, and a GP in Hamilton. Dr. Sharon Sime, a Chief Clinical Advisor, National Investigation Centre and National Public Health Service in a public health position. Dr. Rebekah Hayman, a consultant and paediatrician at Starship. Dr. Sue Tutty, Primary Care Advisor to Whatu Ora, Counties Manukau. And Dr. Luke Luk, Primary Care Advisor to Whatu Ora, Counties Manukau. So we will head over to the measles discussion. Thank you.
So kia ora koutou, thank you all for coming tonight. I'm just going to whip through from a GP point of view a quick measles update. It's quite a timely reminder as we've got lots of the FIFA Women's World Cup matches coming, and we're expecting lots of international travellers in. So that's kind of one of the real high risk times when measles may be reintroduced back into the country. So we thought it was a great opportunity just to give a quick reminder. I'm going to run through a quick signs and symptoms, and then we'll hand over to Sharon from the public health perspective. You will know most of what I'm telling you. Mine's just designed as just a quick reminder to you all, just to jolt your memory. So we all know measles, highly contagious virus. The one thing I just have to keep reminding myself is it does occur in all ages. We tend to just associate it with children, but all ages. And as mentioned there, does have an incubation period of about 7 to 18 days. Day 0 for the measuring when you're infectious. Day 0 is the day that the rash is onset, and you're infectious from 4 days before until 4 days after. I just always like to throw a bit of humour in there. Of course, we know it's something to worry about. Now, again, you'll know this, I'm not telling you anything new, and remember to look on Health Pathways. They have all this great information on there for you to look up at the time as well. Initially starts as snotty nose, cough, runny nose, can get a bit of conjunctivitis, and then the high fever starts. Now, usually the high fever will continue for at least 24 hours after the rash decides to appear. And the rash, you probably know this, generally starts on the face, behind the ears, maculopapular rash, and then starts spreading down to the rest of the body. And generally the kids don't look very happy. They've got high temperatures. They look quite miserable. There's always mention of Koplik spots that are usually present a day or two before the rash begins, and they usually only last a day or two. I've not put any pictures up because it's not really something we see often. So I didn't think I'd dwell on that for you. Really important before they come in is just if you're doing triage, or if you're aware that someone's coming in with a rash beforehand and you think they might have measles. COVID has taught us a lot, learning to keep them separate from other people within the practice, and it also gives us the opportunity to ensure that any vulnerable staff aren't involved with the care if at all possible as well. So that's if somebody's pregnant, if you know they're not immunised against measles, or if they're immunocompromised. And again, teaching you to suck eggs using appropriate PPE. So when patients arrive in the practice, if they're being seen in the practice, they're offered a surgical mask on arrival, and there's alcohol gel, hand wash, keeping them separate, putting them in a separate room if possible. And if that's not possible, consider seeing them out in the car. And as mentioned there, other factors to consider when you're trying to rule out in advance, do we think this is measles or not, is have they had any recent overseas travel or contact with someone that's returned from overseas, or contact with someone who's a suspected case. Again, a quick look through the PMS, have they been vaccinated with MMR? Bearing in mind the highest risk group are those between 1990 and 2005, when there was a swap over and change in schedule. So some people may have missed out on a second dose, and obviously those that have got any form of compromised immunity. Let's hope this doesn't happen over the next month or so with the World Cup. Now, evidence of immunity, this is from a public health perspective. So at the moment, those born before the 1st of January 1969 are considered immune. Documentation of previous immunity or infection, and then I will leave you to read from the ages when 1 dose is relevant and 2. There is some debate around this at the moment, and in a second I'm going to get to vaccinations and we'll talk about some of the recent updates from vaccinations and some of the controversy. So this is probably my most important slide to mention. The big thing, if you suspect measles, if you've assessed the patient and you strongly suspect that it could be measles, notify on suspicion. I think that is, and I've put it in red because that's one thing that's very different from anything else. Most other diseases, we wait until we have the positive result. It's really important you notify on suspicion and do it that day urgently. And then also testing, it's not serology, it's done by a nasopharyngeal swab and is done via PCR testing. Serology doesn't really have a role in the acute diagnosis. And then this is written on health pathways as well, was something I learned this time, is consider vitamin A supplementation to those at high risk of severe complications from measles. And there's a list of conditions there for you, for those that are relevant. Now we couldn't do a measles update without mentioning measles vaccinations. This is just 24 months immunization in total. I'm telling you stuff that you already know, is that immunization rates have been going down over the last few years even, and Māori and Pacific have been going down quicker. This is just looking at some MMR specific data in children up to 2 years of age, and again shows Māori and Pacific people below ideally where we'd want it to be, as well as total as well. So we have got some of the recent years people being more vulnerable. And then just a quick thing showing very similar data. So this is what I talked about. There have been some recent changes to MMR vaccination announcements by the National Immunisation Programme. So I've just summarised those there, that there is now an MMR 0 dose, which means they would still need 2 more doses of MMR. And if it's previously the minimum age was 6 months, that's now been reduced to 4 months and can be given for travel or for an outbreak, or if it's post-exposure prophylaxis can be given from 6 months. And National Immunisation Programme have also said that an MMR administered from 11 months of age can now count as your MMR 1 dose. So as it's got written there, if it's for travel or for an outbreak, or if they happen to come in to see you a week before their 12-month birthday. At the moment, that is just being worked through with public health as to whether that will be used as evidence of immunity going forward. So there'll probably be some updates coming out about that in the next few months. And they've also changed the wording slightly around that date of those considered immune prior to the 1st of January 1969. They've now added in individuals who are susceptible could be considered for MMR vaccination. And so that's to try and cover those that have come in from abroad that you think may not be covered. And then just a quick mention on measles prevention. You'll know this, really important, you know your staff's vaccination status and encourage them to get immunised if possible. Ideally, you'd have some way of knowing phone triage or something that these patients might be coming in and plan ahead how they're going to come into practice. If there's an outbreak, consider signage at the entry to the clinic. And then I've just written on there what to do if you've had somebody with suspected measles in a room. Leave it vacant for 60 minutes and then that's how you clean. So that was just a quick whiz through. Sorry if I talk quickly. I'm now going to hand over to Sharon Sime.
Thanks, Bex, and thanks everyone for inviting me to talk about public health management of measles, which is my passion. So as Bex mentioned, measles is on our doorstep. We can see that we've had 5 incursions of measles in New Zealand this year, and that compares to no incursions in the last few years. So we're seeing more measles, and this is in the context of a big increase in measles cases globally in countries where we get frequent travellers, including from Indonesia and India, and also in the context of the World Cup that Bex mentioned, we're seeing outbreaks of measles in Europe. So Austria has a big outbreak at the moment. So there's more measles around. That makes us vulnerable. We're having more international travel to and from New Zealand. That makes us vulnerable. And then we don't have vaccination rates that are high enough to prevent transmission. We require 95% of the population to be fully vaccinated to prevent outbreaks. That combined means we're waiting for an outbreak of measles. So in the last year, Te Whatu Ora has confirmed their measles response plan, and you can see in the slide that we have 2 phases to a response: a stamped out phase, which many will be familiar from our response to COVID, and a focused response phase. Both of these phases have an ultimate goal of elimination of measles. We do not expect, and we're not planning to move to a manage it phase or a living with measles phase. We are committed to eliminating measles. And we're committed because we have committed that to the WHO. We have our obligations to our Pacific neighbours, and we need to do this to protect our own population. We have many other important goals in our response to measles, which will include meeting our Te Tiriti obligations, assuring equity and minimising the impact on measles. So the big question that we get asked is elimination achievable? It was debated with COVID whether we should commit to elimination, but there's no debate when it comes to measles. We can and we should eliminate it for a number of reasons. We know a lot about measles. It's a stable virus. It doesn't change. We know how it's transmitted. We know its infectious period, so we know when we need to isolate our cases. We know its incubation period. We know when to quarantine our contacts, and importantly, we've got time to quarantine contacts. Contacts don't need to quarantine until 7 days after their first exposure to the case, so that gives us time for our public health actions. Measles is only in humans, so we don't have this humans pass it on to animals and they give it back to us. And then most importantly, our vaccine is incredibly effective. It stops transmission, provides lifelong immunity, and it prevents and controls outbreaks. And importantly, our public health services have capacity and capability to respond appropriately. And so how do public health services respond? You'll be pleased to know that burning down houses or bombing whole cities is not part of our public health arsenal, but public health management of measles is intense. Case management, it requires looking after the case in all ways, ensuring that they can isolate appropriately, monitoring them, providing them with supports they need, and importantly, liaising with clinical teams if there's evidence of worsening symptoms. Most public health services will monitor cases daily, so they get at least daily contact throughout their symptoms and their isolation period. A very important part of case management is investigating to assess who the case's contacts are and which places they've been to which could be high risk of exposure. So in the current climate, we're doing a lot of planning for the potential for a case to be at a World Cup game and how we would manage that. In terms of managing the contacts, the public health service identifies who a contact is first. And for measles, it is so infectious that almost anyone who's been in the same room as a case would be considered a close contact, and certainly anyone who had any face-to-face contact with a case. But after that, the assessment is about, are these contacts immune or not? So are they at risk of infection? And if a contact is immune, they are not required to quarantine. So there are lots of advantages for individuals to be fully vaccinated or immune. In some circumstances, contacts who are partially immunised will not be required to quarantine, but instead would be restricted from attending high-risk settings, such as healthcare settings. That doesn't mean that they can't access healthcare. It means that public health services provide guidance on how to, that contacts must phone ahead and not just turn up at a healthcare setting, particularly if they have symptoms consistent with measles. And then an important part of management of contacts is determining who should receive post-exposure vaccination. So if a vaccine is received within 72 hours of exposure, the contact is unlikely to need to quarantine. We'll consider them immune as if they've had one previous vaccination, and some contacts at risk of severe disease should receive immunoglobulin to prevent severe infection. Public health services do a lot of other things to manage the wider public health risk. Communication is key, and communication with our stakeholders, particularly our primary care colleagues, is a key priority of any response. So measles and then a vaccination response is likely to be part of any response to a case. And this is the final slide. Apologies for taking extra time, but what I'm trying to convey here is that we have to work together to eliminate measles. Whilst that we are responding to a public health threat, we couldn't do it without our clinical colleagues, and which is why I'm grateful to be here to talk to you. And speed is paramount. As Beck said, notifying on suspicion is incredibly important for measles. The earlier public health services are aware of a potential case, the earlier they can identify contacts, high-risk exposure events, and take action. Importantly, because we have time to quarantine contacts, we can eliminate those contacts who don't need to quarantine at all. So that could end up prevent schools from having to close, workplaces having to close, and so it significantly minimises the impact on society. Preparedness, vaccinating in advance of a case coming, good surveillance to make sure we identify cases early, connected IT systems, those are all vital, and that's the capacity we've built up over COVID. And then our commitment to continuous quality improvement. Our 5 measles excursions to date have tested our systems and processes, which have all stood up, but we've learned a lot and improved them. So we feel we're ready for the next case. And what we ask of you is please notify on suspicion. That's all from me. Thank you.
Wonderful. Thank you so much for that, Rebekah and Sharon. So we have a few questions coming through. The vitamin A that you mentioned, Rebekah, is that funded by Pharmac, and what sort of supplementation regimen would you expect people to be on? Do you have, are you able to speak to that, or would you recommend looking at health pathways and
Very good questions. So there is a regime that's written on health pathways if you wanted to look it up on there. As far as whether it's subsidised, I'm sorry, I don't know that. I would redirect you to either have a chat with your local pharmacy or have a look in New Zealand formulary. Sorry, I don't have that information off the top of my head.
Someone's just wondering about the different categories for post-exposure immunoglobulin, saying that is it only for non-immunised pregnant females, or are there any other categories that we can get people in under?
It is indicated for other people, particularly those who are immunosuppressed, immunocompromised, and potentially infants under the age of 12 months, and premature infants particularly at risk. So those at risk of severe disease.
Lovely. And if someone is exposed to measles but has immunity from vaccination, can they still transmit the measles to at-risk non-immune family members?
In general, no, because it is such an effective vaccine, it prevents infection. So by preventing infection, it prevents transmission. But of course, it's 99% effective. So there's always those very rare circumstances, but in general, we would say no, not at risk.
Okay, lovely, thank you. And in terms of promoting vaccination, obviously, we really want to make sure that people are really aware that measles vaccination is very effective, and we want to get that promotion out there. Is there anything else that's going to be going on?
Immunisation team has been running multiple campaigns encouraging vaccination, particularly in the most vulnerable groups. So I think it's an ongoing campaign to promote immunisation. I would expect if we had a case, particularly if there was evidence of transmission, that would absolutely be ramped up, and with priority given to the region affected, likely priority given, just acknowledging I am not from the immunisation team. So
And I have to say, primary care teams do a fantastic job at trying to get these immunisations into people, and it's trying to look at different and new ways, because some of it's just still not working for some groups of people. So trying to think of it in different ways to be able to get these immunisations done.
Is there any other advice or support that you want to give to our primary care clinicians out there before we sign off?
The only thing I would say is don't be afraid to contact public health, even if it's not measles. I'd rather that you told them about cases that weren't measles than you didn't tell them about cases that were. And that's your job, is to separate those out.
Yeah, it's that notifying on suspicion that's the most important. And that is what's different from lots of other notifiable communicable diseases. So.
All right, so we're moving on to our next section now, which is jaundice in infants with Dr. Rebekah Hayman. Thank you.
Kia ora koutou. Thank you for the opportunity to come and talk. I was asked to come and talk about jaundice, and I was well, actually, first of all, I should clarify that I work at Kids First in Middlemore in South Auckland, Nova Scotia. And I was asked to come and talk about jaundice tonight, and I was a little bit concerned to see that it was talking about updates and new things about jaundice, because this is really all quite sort of old news, but it's more about just some things to watch out for. So this is just a picture of obviously a yellow baby, and one of the tricks for seeing if they're jaundiced by having a look at their skin after you've put some pressure on, just like when you do a capillary refill. So the reason that I wanted to come and talk to you was because we have been having quite a high incidence of late presentation of biliary atresia. So at Kids First, we get at least 3 of these a year. And last year I was involved with one that passed away, died. And this is obviously very sad and very preventable. And I think it's also really interesting to put it in context of Aotearoa, which is that we have a higher rate of biliary atresia in Māori and Pacific infants. So in the population that I work with, this is a high population risk. And there is a big discrepancy in the age that they are that they have this detected, and this makes a huge impact on the outcome. So when you have a conjugated hyperbilirubinemia from a biliary atresia, it's a race to have a Kasai operation, which will then protect the liver. And if this doesn't happen, then you're more likely to need an earlier liver transplant and present in end-stage liver failure. And it's a lot more complicated. You have a higher perioperative complication rate and death, and are a lot more unwell. And for some reason, this is something that is disproportionately affecting our Māori pipi and Pacific pipi. So this is just sort of going through some of our experience. We just about, as I was saying, every year we have around 3. I think we've had at least 1 this year, and we had at least 3 last year. When they present, they are usually, it's to us as paediatricians, it's quite obvious they have full signs of end-stage liver failure and have clearly been unwell for quite some time. So one of the cases, this was their blood tests when they came in, so you can see that the conjugated component of their bilirubin is extremely high, and they have an associated hepatitis and also synthetic function affected in their liver. So I suppose what I just wanted to talk about was having a pathway, and I know that probably most of you aren't meeting these babies until 6 weeks, which from our perspective is too late. And they're going to be falling into late presentation of a conjugated hyperbilirubinemia. But if you were to meet them before their 6-week check or at their 6-week check, or if you had a call from a midwife, or there were midwives in the audience tonight, the thing that I would really want you to take home from this is to have a bit of a pathway for how to approach these babies, and to not and to be a little bit scared of the jaundice baby. So I know that jaundice is really common, but we shouldn't dismiss it without thinking about it. So this is just the way that I sort of divided up in my head, just really straightforward to try and have a bit of a pathway. So the times that I worry about jaundice are when you have a very young baby, so that presents with usually a jaundice and a unconjugated jaundice within 24 hours, and that's usually from an ABO incompatibility, and they might have evidence of hemolysis. And these babies are at higher risk if they're premature, if they're septic, and they're usually very young babies. And the thing that they're at risk of is getting a really high level of unconjugated bilirubin, which can cause kernicterus, which is it causes damage to the brain, go on to cause a severe cerebral palsy, and it can also cause death. So that's it starts early, and it's the time that you'd be getting questions would be in the first sort of 1 to 2 weeks of life. I think it's really important to remember with this group that the way that it's causing problems is by causing hemolysis, and that associated with this, you can also get a severe anemia, and the time that will be at its most high risk will be around 6 weeks. So I'm not sure if you can recall back to our physiology days when you transition from fetal hemoglobin and you're transitioning to a more adult type hemoglobin, and you get a natural nadir in your hemoglobin. So all babies will have this. And then if you have hemolysis on top, then this will be an exaggerated nadir. And we've had some babies will get really low hemoglobins. We've had deaths from severe anemia with unrecordable hemoglobins due to the combination of this nadir and the hemolysis. So that's the kind of the other trick to remember with unconjugated early jaundice. But the one that I really wanted to talk about tonight was what we call prolonged jaundice, which I'm pretty sure in my career the time has decreased, and we now say that if it's jaundice longer than 2 weeks of life, which is not very long, and so if you meet a baby who is jaundiced after 2 weeks of age, and then you need to start thinking about, could this be a conjugated hyperbilirubinemia? Could this be a biliary atresia? Really, I know that at Kids First, where I work, we carry an on-call phone during day hours, work hours, and so you can always call us if you're worried. And in this situation, we would just say, get a blood test. So this is just going back to what I was talking about, the early jaundice unconjugated. You want to take a history and look at the risk factors for this. So looking at mum's blood group. If you're suspicious, you might ask for the infant's blood group and a Coombs test looking for evidence of hemolysis. You're checking the bilirubin and a full blood count. So I think that, we all know about breast milk jaundice, and we know that it can cause you to be jaundiced for a long time, but the other message I want you to take home from tonight is that breast milk jaundice is a diagnosis of exclusion. So once you've excluded all the bad causes, then you can say it's breast milk jaundice, but it's very risky to do that beforehand. And if you are asked about how to manage a baby like with an unconjugated hyperbilirubinemia, the first line is hydration, but then the rest of the management is in the hospital setting. We have algorithms to determine whether they need phototherapy or other treatment. And usually the babies that end up in this situation are premature babies. So they've usually been born in the hospital and this is detected as they go. So it's quite rare for this to happen to a baby in the community and coming back in. And so what I really wanted to talk about was the conjugated hyperbilirubinemia, which is 2 weeks. So if you meet one of these babies, it's really important to do a full examination, concentrating on their feeding and their growing. And just remembering what the signs of end-stage liver failure are. So they're actually quite similar in babies and children. So they'll get hepatosplenomegaly, they'll have skin changes, not just jaundice, they'll also have caput medusae, splinter hemorrhages, things like that. So I'm going to talk a little bit more about examination of the stool colour. This is really important, and I think that you either need to cite it or you need to be really clear with the whānau about what you're talking about. So I think quite a few of the cases that we've seen, the parents will report that the stool is normal, but actually it's because they have never seen a normal baby stool, and so they have nothing to compare it to. I think there's also some fluctuation in the level of colour, and so the earlier that we want to pick it up, the less likely that we're going to have this, which is another reason why I would be recommending that we would do a blood test looking and just checking their bilirubin if they were jaundiced. And then if you were highly suspicious, then you would do other blood tests with it, so full blood count, thyroid function. There's other things that can cause conjugated hyperbilirubinemia. And checking that you've done a newborn screen, which is another thing that would also cause, could be another cause. And so this really gets me to the kind of important question, which is you're sitting in a busy clinic and you have a yellow baby at 3 weeks, and you say, does your baby have normal stool? And mum will say yes. And now I've got some beautiful pictures of acolic stools. So this could be called yellow. So I think you can see there's a range, and I think you need to have either see it or actually show pictures to be really confident to be using this as a reason to avoid doing a blood test. And that in lots of places internationally, they have some little cards that will actually have pictures of the stool on them and examining a yellow baby. So some of the issues that we've talked about have been within the group at Kids First is people think that it's difficult to examine a baby with darker skin for jaundice. At the beginning, I showed you that picture of pushing and seeing what the skin colour when you put pressure on is underneath, and if they're jaundiced, also looking in the eyes is the other place. And then also looking at the stool. So the Paediatric Society of New Zealand does have a gastroenterology network, and they are thinking about ways that they could try to support identifying these babies earlier. And one of the suggestions is that there would be these cards similar to this one that I've got on screen here. So both to empower parents to kind of be paying more attention and aware, but also to use as a screening test when you see a baby. So this one is a sort of screening stool picture that you might have. So I suppose in summary, what I just wanted to talk about tonight was have a bit of a framework for babies that are jaundiced. Early jaundice is probably going to be a conjugated cause, and the thing to watch out for is that 6-week nadir when you might get an associated anemia, a conjugated hyperbilirubinemia from 2 weeks of age. Make sure that you don't dismiss it as breast milk jaundice without at least checking the bilirubin. When examining a baby for jaundice, pay special attention to their skin and have some different strategies for how to identify the colour of their skin. Don't just ask if the stool colour is normal, because this is probably not going to get you a helpful answer. Either have some examples of some pictures or ask to actually see the stool yourself. And I also think it's really useful to examine these babies. So the baby that I was involved in last year came in very sick, and really if they had been examined, that would have been picked up, I think. So thank you for listening tonight.
There's a question here just asking, how would you treat jaundice? Is it phototherapy or is it a billy blanket? Or, I mean, obviously it's inpatient treatment if it requires it.
So I mean, I think the two different types that we're talking about. So if you had a unconjugated, it's usually happening in usually premature babies are the ones, and then a very smaller subgroup that will have a severe hemolysis. And in that situation, we'd start with phototherapy, which could be from a billy blanket, and then lights, making sure they're well hydrated, so the breast milk fluid going through their gut helps to wash the bilirubin away, and then it will stepwise into having an exchange transfusion or But I think what's more important is to think about these higher risk ones with the conjugated hyperbilirubinemia. So the one that I'm talking about tonight is biliary atresia, but there are lots of other causes of the conjugated hyperbilirubinemia, and all of them are serious. So sepsis is one. There are other liver malformations that can cause it. There are inborn errors of metabolism that can cause it. So all of these things are serious causes. So it's just a clue that is letting you know that this is a hospital level problem, and pretty soon starship tertiary quaternary level intervention needed. So we get quite anxious about these babies.
Yeah, fair enough. And what level of unconjugated bilirubin should be ringing alarm bells for you? I mean,
yes, I didn't really point that out, did I? So if you have 20% of your total, so if you had a bilirubin level of 100 and 20% of it was conjugated, then that would definitely trigger a few more investigations. That's not really high. That example that I showed you, it was pretty much almost 100%. So it's a percentage of the total, or if an actual conjugated number was higher than 20. And if you think about it and compare it to those babies early on that have an unconjugated hyperbilirubinemia, the numbers of bilirubin that they reach in their blood is much higher. So for a term baby that is going to need phototherapy, you'd be looking at numbers around 450, whereas that baby that had end-stage liver failure, they had a total bilirubin of around 130, 40, and the conjugated part of it was about 120, 110. So I think that when you see a lot of these babies, they look different too. So that conjugated hyperbilirubinemia makes them look a little bit green. We sort of talk about it like a papaya. You know how papayas have that yellowy, greeny look? So they get that sort of look. So it can be quite hard to, I mean, I think you can see it when you look at them, but it is a different yellow to the yellow that you're getting from those early babies. So that was 20% of the total, or an absolute number above 20 of the conjugated fraction.
Thank you very much. That was extremely thorough. So we will be moving on now to Sue Tutty. Thank you so much, Rebekah. I really appreciate you speaking tonight. Sue will be discussing abnormal uterine bleeding, the audit and the learnings. Thank you, Sue.
Well, thank you for the opportunity. And I thought I'd just present this audit tonight. It's on some work that we've done at counties. So it was between July 2021 and November 2022. So 16 months of work. And it's looking at the AUB pathway. So this is the county's pathway, which is on health pathways. And there's also a Auckland pathway, which is slightly different. So I'm just showing them both so that you know that there is some slight differences, mostly because counties require more investigation, so that we've asked health practitioners to do PAPELs for all women with the diagnosis of AUB, whereas in Auckland and Waitemata, it's more dependent on the endometrial thickness on the scan. So just to be aware of those slight differences on criteria. And this is our success with our work that we've got to. So I was thrilled in March this year that we got up to 115 interventions in the month. We had aimed to do 60 by December and over 100 by March. Unfortunately, April's fell back down again. So we've still got work to do there. But that's very pleased to see that we did get at least there for March itself. This is just looking at the ethnicity of the people. In the Pacific group and the European group are about the same size at 32%, and our Maori group at 19%. So we're reaching the sort of population that we need to be reaching. And I just had a look at, this is just against census data to look at our Pacific population. And it does show that there are perhaps our Tongan women and our Niuean, although it's hard to say much about the Niuean women because the numbers are so small. But it may be that we need to concentrate more on presenting this to women to inquire about their bleeding and not necessarily rely on them always to come to us. And as you would expect, the claims are for the majority of women are in their 40s. So what I did in the study, there was 738 women that were in that time range, in that 16 months. And I sampled them, initially taking every 5th one and then every 10th case, so that we got down to 80 women. 7 people did not require the service, so they'd been wrongly put into there. There were 5 women that weren't seen in primary care, but were seen directly in secondary care, so we didn't have the opportunity to intervene in their cases. And 7 women who were referred directly without doing any investigations in primary care, and 1 woman that was not sexually active, so we wouldn't be expected to do examinations for her. So that got us down to 60 women that I examined the notes for. Of those, 82% of the women had had a PAPEL or a PAPEL attempt. So that was really pleasing, actually, in this audit. It's much higher than what I found in audits that I've done in other years, and a really, really good result. It drops a little bit to 73% if we include those that were referred prior to the PAPEL being taken. And I'd just like to make that point that even if the scan comes back and says this woman needs to be referred to secondary care, please still do the PAPEL, because by doing that endometrial sample, we get so much more valuable information, and it means that secondary care can act on that more quickly and organise the woman's care. 83% of the Propels were successful. I took this to my secondary care colleagues and they were over the moon. They felt that that was a really good result. And I had checked as I went through the audit, and some of the ones that were unsuccessful in primary care were also unsuccessful in outpatients, and the woman needed general anaesthetics to be able to get their samples. So actually we're doing very well in getting the samples, and 21% had a Mirena attempted, which is perhaps a bit lower than what we could achieve. 61% were referred to secondary care. We had in other audits that I've done other years, we thought it was about 50%. And so I looked into some of these referrals, and some of them were avoidable. Some of them were just for advice. 2 were declined because they hadn't had a Propel. 1, the clinician just gave back the advice that the woman needed a Mirena, and 1 just didn't need a referral. So I think if we took that 13% away, we'd be down to about our 50% referral rate, which means that 50% of the women that we see with abnormal uterine bleeding can be managed completely in the community. So when I looked at this work, in fact, most cases had been investigated and managed according to clinical guidelines. 1 case was concerning, it needed clinician follow-up, and I contacted the practice and they said, oh, yes, we know, we've been trying to track that woman down. So that was also very pleasing to hear. 2 cases needed a Propel, but they'd only just had their scans, so I think that that was probably in process at the time I did the audit. And 2 cases had other things that turned up on their scans that needed following up. 5% of the cases had cancer. So we are picking up cancer in this. 1 of those had been referred without having a Propel done, just on the scan result. 1 had been referred, and then the message came back to the GP saying, please do a Propel, which was done. And it was really pleasing to see that that result was then available when the woman turned up for her first specialist appointment, and they were able to plan her care much more thoroughly and have that conversation with her than they could if they hadn't had that histological result. 1 scan in Propel had confirmed cancer, and she was referred privately. So again, the diagnosis was made in primary care. And in the last case, again, it was diagnosed in primary care, although the woman was admitted simultaneously because of her bleeding. So recommendations going forward, really to be aware of the morbidity that's happening in our community from menorrhagia, to look out for women that might be sitting in your waiting rooms with anemia, looking pale, and to offer them perhaps even a blood count, or to start to discuss their periods. That sometimes women are reluctant to come forward. Sometimes it's just what they consider to be normal, even though we know that that extent of bleeding is not normal. We also know that there's a number of people turning up at hospital with profound anemias that we could have treated earlier. So to intervene earlier in the course of the menorrhagia also gives us the chance to treat this adequately. And by putting in a Mirena or providing progesterone cover, you may actually prevent progression to an endometrial cancer. And the other recommendations from my audit, do the endometrial biopsy, do the Propel, even if the woman still needs a referral. Think about putting a Mirena in. Obviously, it's the woman's choice, but I think that you can discuss this. If you can't put on a Mirena yourself, then look for a colleague who can. And just because it's something that we might not be experienced to do, does not mean that we shouldn't offer it to the woman. it may be, if you can't do it, yes, refer to a colleague. And also, if you're seeing patients that have been seen in secondary care, and particularly in ED, where they may have had their anemia managed, they may still need management for their menorrhagia. Do call them back in, do offer them a Propel and a scan and a workup and a pharyngect, and for that comprehensive care that we know that primary care can supply.
Thank you, Sue. So there is just a question about the Health NZ changes and whether the criteria will be the same for everyone, no matter where they live, basically.
There are different criteria at the moment, as I said at the beginning, but there is certainly work done to try and nationalise the criteria for the AUB work. There is research happening at counties to look at some of the results with our patients, to look at age and endometrial thickness and some of those criteria to see what we need to provide as a national indication. The difficulty is that in counties we have so much a higher rate of endometrial cancer than most other places in New Zealand. So we need to find criteria that will work for the whole of New Zealand, but not disadvantage if there is a difference with the populations that we serve.
Yeah, definitely. And in terms of making sure that we're capturing those people and getting the funding that we need in primary practice as well, we've got wonderful POAC. So does POAC still pay for unsuccessful marinas and Propels?
Yes, it does. If you've attempted a Propel, we're not going to be able to get to do them all. And so it's yes, they will pay for an attempted Propel.
And what about DNAs? I know from personal experience working out in counties that we used to get a lot of DNAs, unfortunately. There was a lot of fear, as you mentioned. There's it is a really hard thing for some women to come forward and get Propels. It is quite an invasive procedure.
I think that we need to use our practice teams, really. We don't pay for DNAs. There's a lot of evidence that if you ring women and remind them of their appointments, if you explain the procedure, you know, if you're referring from one GP to another, I think it's very good to be able to explain what's going to happen and get rid of some of that fear. It's not a pleasant procedure, but it shouldn't be particularly painful to have a Propel in endometrial biopsy taken. I think our health coaches that a lot of our practices have a role in talking with women and trying to allay some of their fears, just as some of the cancer nurses are working in practices in secondary care. And if you have access to Kaiawhina and that supportive workforce, then I think that we should make use of that.
We're going to be moving on now to the clinical update section with Dr. Sue Tutty and Dr. Luke Luk.
Luke, we're heading into winter now, and I understand that you found some really good resources for winter illnesses.
Yeah, certainly. So winter has been quite busy, and thank you every GP that is in the seminar today, and all the one that working quite hard. But recently I've been seeing quite a few cough and cold patients, and I just thought I found some good articles that I would like to share that with everyone. I'm not sure if everyone familiar with BPAP, but if I just search BPAP NZ, and then I will find the latest articles there. And what I can see that is they got some information about managing COVID as well as seasonal viral illness. So most of the things we already know, but I found that it's quite good to go through that with the patients. If they got cough for a long time, if they got fever, running nose for a long time, what they can do rather than just giving them antibiotics. Most of the patients I come in to say, oh, doctors, I've been coughing for 2 weeks, can I have some antibiotics? But it's actually quite interesting to know that honey is actually really good for coughing and it's as good as any other cough medicine.
That's one of those old-fashioned things that my mother used to talk about.
Yes, so that is very good. Your mother is absolutely correct too. So it's really good that we do that. And I found that this one is actually quite good as well as talk about COVID as well. So again, it's similar symptoms there. but we can talk about to the patients what we can use for their symptoms and what to watch out for. I'm talking about antibiotics and the use of a cold illness. Have you been giving antibiotics for your patients, Sue? How often do you think you give antibiotics?
I hope I prescribe them just when they're really needed.
Yeah, because the other thing that I found from the website is that if you can, everyone can see that there's actually a clinical audit about managing winter illnesses without antibiotics. And it is a college endorsed activity, and I think it's actually quite good for everyone that is due for their CME and for the audit. So seeing 30 patients, and then for the initial consult and then the follow-up consult and doing an audit, that will be a really good idea if everyone need to do the audit. Would it be long for you to see 30 patients? Sue? How long do you think it would take you to do that if you do an audit like this?
I think during winter it would probably be able to do it in 1 week. You've probably seen enough people with winter illnesses, which makes it useful for someone doing a locum, I guess, and not in a regular practice.
Mm-hmm. Yeah, certainly. Talking about COVID, I'm not sure many people see COVID and long-COVID as well, but there's also another article that again is in the latest article here. It's just published in June 2023 about what is long COVID, how do we diagnose that, and what investigation need to be done, and what support we can give, for example, like a multidisciplinary approach, and how long we would expect that to get better. And I think it's important that we normalize that to our patients and say that it can happen, but most of the time, 3 months or 6 months that the patient will get better as well. So it is a good articles that I recommend everyone to have a read. And with the COVID, I think Sue did some update on the COVID webpage on the health pathway as well, isn't it?
Yes, the health pathways have been updated, the COVID pathways, and made a little bit more simpler now. So the 3 pathways have been put into one, with the case management for adults, children, and COVID testing. There's also some other pathways that have been merged, the practice management and reducing the risk of transmission. And the COVID vaccination pathway has had an overhaul as well. So as we're moving more into BAU, business as usual, then these pathways are being being simplified for us, and some of the information moving out. For example, the myocarditis, pericarditis after COVID vaccination is also on cardiology, and the COVID and pregnancy to women's health.
And talking about updates, I think there is something that about the cervical screening that is updating as well. So do you want to talk about that and share that with everyone as well?
People are probably aware that the new cervical screening register was supposed to start on the 26th of July, and that has just been pushed back a bit until the 12th of September. So still coming, but just a little bit, giving us a little bit more time to get organised for that. There are some modules that are available for you to learn about the screening program. There will be 4 modules. The first 2 have been released so far. There was the Goodfellow webinar, as you're showing there, that has a lot of the summary data. That still has the 26th of July date on it, obviously because it was done a few weeks ago. The good news with the change in date was that they also announced that there is some budget being released, 7.3 million towards the screening for the HPV. So that will be helpful. There'll be more details to follow, but it will be for the unscreened and underscreened and for our Maori and Pacific women.
So I think this is the date that has been changed, but there's certainly some good information about that. And I wasn't sure about that until Sue told me about that. But if everyone just have a look on the National Screening Unit website, they got the guideline there, so everyone can have a look.
Yes, so the new cervical screening program will be different from the old one in that it's a population-based screening using NHI data. So it will reach people that are not enrolled in primary care as well. And studies have been done already, but it will be so much more acceptable for women to do a self-swab rather than having to have a speculum examination all the time. Although if the result comes back positive for HPV, then there will still need to be the liquid-based cytology performed. So they may need to come back for a second investigation with the smear test. And the length of time between screening will push out to 5 years, which is also positive for women. So lots of good things happening around the cervical screening. We just have to wait till the 12th of September now.
Yep, no, certainly.
I was just going to warn practices too with the COVID that some of the supplies will stop being funded anymore. So that the PPE is going to be phased out from the 1st of October. We expect that it will probably be November before the medical masks will no longer be supplied, and the N95s probably sometime after that.
There are some questions around the mandates for wearing masks in clinical practice and if they will drop off with the reduction of masks being available.
I think that there's still a advice that masks are worn in the clinical setting.
Do you think there's any change to that in the future? I mean, is there any talk around when that might drop off? Or, I mean, as someone has rightly said, just in time for a measles outbreak, we're not going to be having our PPE funded. So still encouraging medical practices to wear PPE, but if we're not getting them supplied, that is a cost that, practices do need to consider. At
some point, our COVID care needs to transition to business as usual. Mm. And that's the stage that we're getting to.
The main questions we have are around the masks and just around the cervical screening. Is there any particular people that you just want to confirm would only require the HPV testing rather than going for cervical? I mean, at this stage, it's everybody would be eligible for HPV testing, just the swab. And then if they had a positive result, they would then move to LBC. Is that correct?
That's correct. And even if you did liquid-based cytology, they would do the HPV test on it first. So if a woman chose to do that, and she might do, because it would mean she wouldn't need to come back, but they would only do the cytology on the sample if the HPV test on the sample came back positive.
So I just want to thank all of our speakers for being present here tonight. I really appreciate the updates that you've all brought forward for us. And thank you to all the viewers as well. Have a lovely night, everyone. Ka kite.